Hello, this is Professor Wheeler. Welcome to my lecture on trauma disorders. The learning objectives for this lecture, we're going to talk about the various types of trauma-related disorders and identify symptomology associated with each. The disorders we're going to talk about are post-traumatic stress disorder and acute stress disorder. Number two, we're going to identify the 5 main criteria for symptoms for PTSD and ASD. Number 3, which symptoms of PTSD would it be improved by a beta blocker? Number 4, which medications have shown to be effective in treating PTSD? Number 5, discuss various interventions relevant to the treatment of trauma-related disorders. And then a little more in depth, number 6, what is eye movement desensitization and reprocessing? So these are our 2 main trauma-related disorders we're going to talk about. They differ in mainly the length that the person has the symptoms. Generally, the symptoms are the same. Post-traumatic stress disorder, you have to have the symptoms for at least 30 days. And then if it's 30 days or less, then it's acute stress disorder. Post-traumatic stress disorder, usually abbreviated to PTSD. The criteria includes specifying qualifying experiences. So traumatic events, and then there's these 5 sets of symptom clusters, also called criterion, or also known as criteria. And the requirements are around the duration, how it impacts a person's functioning, and other things that might interfere with the diagnosis. So these are the main criteria. So we have the first criteria, criterion 1, there has to be an actual traumatic event, and we'll go into that in more detail. Criterion B, there's like an intrusion into the person's everyday life. So there's flashbacks, or there's nightmares, or feelings like whatever happened is happening again. And then number C, avoidant symptoms, where the person avoids the situations or the place or things around the negative event, the traumatic event. Criterion D, negative alterations in mood or cognition. So the person is significantly distressed by the thoughts about the situation, the event that happened. Criterion E is increased arousal symptoms. It means they have a startle reflex. They're always on guard. And they're always kind of very stressed as just their baseline. All right, criterion A. So there has to be real or imagined threat of death, serious injury, sexual violence like rape, and it can be direct witness or indirect. And when they say indirect, they mean it can be, like if your spouse was raped or assaulted in some other way. It can't be, something like you were traumatized by a scary movie, something like that. It has to be an actual event in either your life or the life of your loved ones. So criterion B, the intrusion or re-experiencing symptoms, these are the memories are, we have these things called flashbacks, where you feel like the situation is happening again. You have, the pulse starts pounding, and you're totally on guard and stressed, just like the thing is happening again. It feels like it's happening again. We have nightmares related to the event. The nightmares, sometimes they, our dreams in general are symbolic, and sometimes the nightmares, you really have to think about the feelings in the nightmare to understand how it relates to the traumatic event. Sometimes it's not always obvious. Just the intrusive thoughts where you're trying to go about your day and you can't help thinking about it all the time. Um, in the psychological and physical reactivity. So when the anniversary of the event arrives, it can be another traumatic event. I mean, it can be a traumatic process to bring it all back when there's an anniversary. Sometimes patients will need to be rehospitalized on the anniversary of their traumatic event. Criterion C, avoidance symptoms. So the person alters their life to go out of their way to avoid things that remind them of the traumatic event. Also, they'll avoid the people in their life um, that remind them of the event. And part of some of the sad situations in this, it can be the people that they avoid that remind them of the event can be the people that were actually trying to help them in the couple days after their traumatic event. And now they see that person and it just reminds them of the traumatic event. So they avoid the people that may have been their support system. Criterion D, negative alterations in mood or cognitions. Cognitions are another word for thoughts. And so the person is significantly distressed by thinking about the traumatic event, and it shakes what cognitive behavior therapy people call your core beliefs about yourself and about the world. All of us have these kind of beliefs that are that the kind of beliefs that we're safe in the world if we do certain things, and we that gets shaken when you have a traumatic event. It's like we can't we have to at a deep level of our psyche we have to kind of reshuffle how we could feel safe in the world again. And then this last one, distorted sense of blame for oneself or others. What what happens, we always know that we don't want to blame the victim when somebody is the victim of assault. Um, but with ourselves, we're not always so generous. We, you'll think about, well, I shouldn't have, I'll give an example. If you were assaulted in a bad area, let's say, you might blame yourself saying, I shouldn't have been in that area by myself. I shouldn't have been there that late at night, or I shouldn't have been in that area at all. Um, and that's one reason we'll talk about later why group therapy is helpful is because, a lot of times we can see that other people are not responsible for their assault, but sometimes we're not as generous with ourselves and we still feel guilty and blame ourselves. So criterion D, continued being stuck in severe emotions related to the trauma. They call these traumatic feelings. One of the terms I've heard in the past that seems accurate is it's like they're frozen in time. You can work on them a lot and it still feels like they never change. The feelings you have that are hard, you just feel, they feel stuck, they feel frozen. All right, and then we have our reduced interest in pre-trauma activities, and generally the person's not as interested in whatever they were interested in before, like advancing their career or you know whatever they were working on. They're not interested anymore. They're totally consumed with these symptoms. Another thing is feeling detached, isolated, or disconnected from other people. And when you're going through this, it feels like you can't relate to anyone else that hasn't had this traumatic event. So it's very isolating. Another reason why group therapy is very effective for people that have PTSD. All right, and then increased arousal symptoms, criterion E. And what this means is you're on guard all the time. It's like this deep in your psyche. There's a feeling like, I should have been ready, like I'm in danger. I'm in danger all the time of it happening again, whatever happened. And so you're on guard. What's typical, you'll have just kind of runs of tachycardia out of nowhere where you feel like your pulse is pounding. Um, and along with that, irritability because you're really tired from being on guard all the time. Hypervigilance, which means you're always looking for more danger, and you're easily startled because you're all on guard, and if something happens, it's very disturbing that you're never really able to relax and take things as they come. So for PTSD, these symptoms have to have lasted at least a month and seriously affect the ability to function. And some of the things that can't be related to any drugs you're using or a medical illness. Some of the medical illnesses that can cause these kind of things are things that go wrong with your thyroid that would cause a lot of thyroid hormones. Um, so there's nothing causing it outside of just the event itself. Just whatever happened is what's causing it. There's not, you're not drinking a massive amount of caffeine or other stimulants or have a medical illness. It's commonly seen in veterans of wars and survivors of sexual abuse and sexual assault. Also, physical assault too, of course. And, one of the things that happens is when we have these, somebody that's never had a substance abuse problem in their life can turn to substances just for the temporary relief. Alcohol is probably the most common one just because it's so available. And it's a way of trying to escape those emotions, but it doesn't work, and it can be dangerous because it disinhibits the person and you go further into it. Um, some of the hypervigilance, when you're intoxicated, you might do something dangerous. And so we always worry about, and we always want to do a complete assessment on a patient with PTSD to make sure they haven't started abusing a substance. Very common for somebody that's, like I said at the start of this slide, that's never had any, that's always been a casual drinker or user of, something like marijuana, to heavily start abusing the substance while they're trying to escape their pain. All right, so acute disorder is basically the same as the symptoms are basically the same as post-traumatic stress disorder, but it's within a month after the traumatic event. And so you can look at the same criteria for PTSD and just think all of those still apply. It's just the person hasn't had the symptoms long enough to be categorized as PTSD. the yeah, I'll leave it there. So they can have the same things. Things feel that they have trouble concentrating. They feel detached. Um, Something we call depersonalization and derealization, which I'll talk about in the dissociative disorders lecture, where they feel like the world isn't real and they feel detached, and they'll have memory issues related to the traumatic event. They might not remember specific details or even the whole event at all. That's why our sometimes we'll lock up the wrong people because eyewitness testimony is it's considered to be objective, but it's really not. The person is seeing it through their trauma, and so sometimes in the past they've been susceptible to the police like showing them pictures of the people in the area that they think may have done the assault, and then they'll choose one, but it's, and they'll really believe they're choosing the right person, and then we have famous cases where DNA evidence shows later on that the person was innocent. So for post-traumatic stress disorder, we need at least one symptom from each of the symptom clusters, the criterion we just talked about. So again, this is just looking back at the criterion we're talking about. So we have the avoidance, and then we have the increased arousal. So for acute stress disorder, it needs to be at least a minimum of 3 days and a maximum of 4 weeks. And so if it's longer than 4 weeks, then it's PTSD. Don't worry on an exam, and I don't believe on the NCLEX it's gonna say something like 29 days. It'll be it'll be obvious that the short-term one is acute stress disorder, and the more chronic one, the one that's lasted longer than a month will be PTSD. So treatment options, like I mentioned earlier, group therapy, if they're especially for a specific trauma like a rape or something like that, group therapy is really helpful, for the reasons where you can you can't really relate to other people that haven't had your type of trauma, in the short term when the person is experiencing these symptoms. And then we also have eye movement desensitization reprocessing, which is it's kind of a form of exposure therapy. They're not quite sure why it works, but they are. One thing we are sure of is that it does work, and that's where a therapist they'll be moving their hands in a certain way that the patient follows with their eyes while they're talking about their trauma. And it was thought that crossing the midline of the body, where the person is stimulating on each side of the body, that it creates it makes it where things get unstuck, where the person is they're able to look at the trauma in a different way and absorb it and heal from it. It seems to work the best for people with where the trauma is very visual in their memory. There's a lot of images, and it's it's called eye movement because that's how they did it at the start. There's also different ways where they can do a sound that's on each side of the person, or they can tap the hand on each side of the person. It's something about going across the midline of the body that seems to be the key factor. Some psychologists theorize that it's a form of exposure therapy, where basically we're having the patient recall the event, but distracting them while they're doing it, and so that's what kind of loosens up, where the person can process the images and the feelings. Um, but again, like I said, we don't quite know why it works, but we do know that it works. Then we have cognitive behavior therapy, and the big focus with cognitive behavior therapy for trauma is the person learning the grounding techniques, where they learn how to experience, okay, I'm hearing what I'm hearing. The chair is under me. I'm being supported. Those type of things we'll probably talk about in one of our labs where I teach you relaxation techniques, and that just kind of helps the person kind of ground themselves in the present, realize the traumatic situation is not going on anymore, and and aid the healing. Medications for trauma: SSRIs and SNRI antidepressants plus trazodone to help the person sleep. SSRIs are considered the best one for it. SNRIs have worked as well, and you might think with norepinephrine that wouldn't be a good idea because it causes more energy and can have a side effect of anxiety. But so theoretically, you would think the SNRIs wouldn't work, but they actually do. And so generally, the SSRI is the first choice. And then if it's not effective or the patient's having a lot of side effects, just like for depression and anxiety, we can go to SNRIs. And then to help with especially the startle response and the nightmares, we have our medications that help with the actual physical symptoms, the guanfacine and prazosin, Tenex, and Minipress. Those help the person by decreasing those arousal symptoms. They make it where you're less likely to have a nightmare. If you do have a flashback, you don't have such intense, the pounding of your pulse and elevation of your blood pressure. It helps keep those under control. Now, of course, you always, if you're going to be giving these medications, whatever the situation is, you always have to do the blood pressure and pulse first, because in these situations, we're not giving it for high blood pressure or we're not giving it for a cardiac reason, and so we want to make sure we're not bottoming out their blood pressure or pulse. But they're very effective for helping patients with nightmares and flashbacks. Then we can give a low dose of atypical antipsychotics for agitation. It's usually something, just a small dose of, I think the most common one is probably Abilify that we use for that, and something like 5 milligrams. Not a high enough dose that would help somebody that has actual psychosis, but enough that helps with the agitation. And benzodiazepines, things like Ativan, Valium, and Xanax is used, but you probably know I don't approve of that, but it is used in these contexts. One thing we worry about that is the person could start abusing them, and so we don't want to give them another problem. But they are helpful if you know the patient can responsibly use them, and so for the short term. Going over our learning objectives for this lecture. Number 1, describe the various types of trauma-related disorders and identify symptomology associated with each. We talked about post-traumatic stress disorder and acute stress disorder. Acute stress disorder is very similar. It's just 30 days or less, or 4 weeks or less, depending on the source that you reference. But we won't. Generally, both of those are considered correct. Post-traumatic stress disorder is over 30 days with these 5 main symptom clusters or criteria that we talked about. Number 2, identify the 5 main criteria of symptoms for PTSD and ASD. So we have criterion A, there has to be an actual traumatic event, and it has to have happened either directly to you or somebody that's one of your loved ones, and involved the threat of death or serious injury or sexual assault. The second one, intrusion or re-experiencing. And so in other words, the person has flashbacks where it feels like it's happening again, or they have nightmares, and the nightmares are very disturbing, and they wake up with their heart pounding, and they might be sweaty and very upset, and have trouble going back to sleep, or not sleep at all. And then we have criterion C, which are the avoidance symptoms. And so the person has a persistence avoidance of anything that reminds them of the situation. So if there's a certain area, if they were assaulted at work, they might not be able to go to work. If they were assaulted at their home, they might not be comfortable at their home. And so they avoid everything related to that event. And like I said, one of the things that can be sad is there could be somebody in their life that was actually supportive help them during the event, and they might shut that person out because that person reminds them of the trauma. Okay, and then let's see, criterion D, negative alterations in mood or thoughts. In other words, the person really feels bad about it. They have persistent negative beliefs and expectations, negative thoughts about their self, negative thoughts about the world. I talked about how it really shakes the person at what we call in the cognitive therapy they, theory, they call the core beliefs. It alters how you feel about yourself and the world, and your your psyche has to kind of readjust and reevaluate the things that you thought were true about the world and about yourself and about your safety in the world. Criterion E, increased arousal symptoms, and so in other words, the person is always very irritable and reactive and on guard. It's like they're on guard, thinking it's going to happen again, and so they have to be ready. And then, of course, it doesn't happen. They have what we call hypervigilance, where they're scanning the environment for danger all of the time. Um, they're easily startled, and when you startle them, they really really freak out. It's not normal, and they can't concentrate, and so that's why that they wouldn't do well in a program of study like a nursing school program. All right, and then number 3, which symptoms of PTSD would be improved by a beta blocker? So the beta blockers we talked about were guanfacine, brand name Tenex, and Prazosin, brand name Minipress, and those are medications that make it where your pulse can't suddenly jump really high and you can't have that big panic response. And so the symptoms that really helps with are flashbacks, helps with the nightmares, um, helps with the arousal symptoms, and so those are really good in helping the patient, whoever or the client, I guess we're supposed to call them these days, deal with these feelings where they're trying to heal from their PTSD. Which medications have been most effective in treating PTSD? We have our SSRIs that increase serotonin. If the person can't really tolerate those, we also can use SNRIs. Like I said, even though they increase your norepinephrine, which can increase anxiety in some people, they have been found to be effective in treating PTSD. Then we also have another one from our antidepressant group that is mostly used for sleep, which is trazodone, which has the side benefit sometimes of making where you don't have a lot of dreams, and so it's a side effect, but it can be useful for PTSD patients. We also have our like we said, the ones in the beta blockers. Then we have a low dose of atypical antipsychotics, not really enough that would help somebody with psychosis, but just enough to help with a little agitation. So an example of that would be like Abilify 5 milligrams, where most people with psychosis, they need at least like 15 or 20 or 30 even to help with psychotic symptoms. Then for short term only, we can use benzodiazepines like Ativan, Valium, and even though I'm against it, they do use Xanax, which is if you know from my substance abuse lecture, I don't like that one because it has too much of an addictive potential. And remember, we we always worry about patients with PTSD abusing substances, and so we don't want to give them something where if they drink alcohol on it, something like Xanax, they might overdose on accident. And so I don't have it on the objectives here, but we always want to assess anybody for PTSD. Are they abusing a substance in an attempt to cope? A lot of them will have some dangerous alcohol use or other use, usually of something that's like it's a depressant. Like I guess marijuana would be used in that situation as well, although although it's not officially a depressant, it usually is. Patients use it to calm down. All right, so that's it for our trauma-related disorders lecture. Thank you for listening. Sorry, my ending there was a little premature. So the various interventions relevant to the treatment of trauma-related disorders. So we talked about psychotherapy, particularly group therapy for specific trauma. And the example I give is, for somebody that's been a victim of rape, for example, those kind of support groups are really helpful because you can see, you can see in other people's story that they weren't to blame, of course. But sometimes we're not always that generous with ourselves. And then cognitive behavior therapy with a real focus on grounding techniques where you are real focused on the here and now, like the seat under you and the environment you're in, and just kind of nailing yourself down to the present. And then number 6, we have, which is also an intervention that could be in number 5 as well, but eye movement desensitization and reprocessing. So this is where the therapists have you with your eyes follow their hands while they're doing a movement that crosses the midline of your body, and moving your eyes in that way while you're talking about the traumatic event. We've seen that's really helpful in helping people get unstuck. And it's famous for the eye movement. That's how it first started out. But remember, it can also be like tapping on the hands, the alternate hands to go over the midline. They've also done it with sounds that are on each side of your body. And so there's different ways of doing that, and we don't quite understand why it works, but it's been very effective. All right, so that really is the end of the trauma-related disorders lecture, and thank you for listening.